Zoll Life Vest is a proud sponsor of CardioNerds. Zoll has continuously improved Life Vest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest Life Vest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Hello, my name is Dr. Naima Maksoud, and I am a cardiology fellow at the Temple University Hospital in Philadelphia. I am a CardioNerds ambassador for my program, as well as a chair for the EP Subspecialty Committee. Join me at the AHA Scientific Sessions 2024 from November 16 to 18 in Chicago, with the pre-session symposia and early career day on November 15. I'm really excited about unique sessions on AI-focused topics and interesting educational content on areas like immunology, gene therapy, and non-pharmacological intervention science. This year marks AHA's 100th anniversary. The CardioNerds Conference Scholars will also be there. Don't miss this exciting opportunity. Register at scientificsessions.org.
And when registering, be sure to use the code NERDS, because if you're among the first 20 to sign up, you'll receive a free 1-year AHA professional membership. And with that, let's get to the show.
Hey CardioNerds, this is Rick Ferraro. I'm an advanced imaging fellow at the University of Michigan and previously did my general cardiology fellowship at Johns Hopkins University, where I had the great privilege of learning for a number of years from my co-host tonight, Dr. Dan Ambinder. Dr. Ambinder, how are you doing?
I'm doing fine. I'm so excited to meet our special guest and learn about a great case in cardiology.
Absolutely. So we have an incredible case tonight coming from the great state of Nebraska and a couple great guests tonight. Mansi, would you please introduce yourself to the guest?
Hi everyone, my name is Mansi Oberoi. I'm a third-year cardiology fellow at University of Nebraska Med Center in Omaha. Originally, I was born in India. I did my med school there, and then I did my residency in Sioux Falls in South Dakota. Now I am doing my cardiology fellowship. I'm interested in pursuing advanced heart failure and transplant, and will be soon interviewing for the fellowship and hopefully land at a good place. Besides cardiology, I love food and I am a big foodie. I also like to travel and try new cuisines everywhere I go. Indian food remains my favorite, but I also like sushi a lot. So this is me, and I also have a co-fellow, Mohan.
Hello everyone, I'm excited to meet you. I'm Mohan Gudiwada, currently a first-year fellow at University of Nebraska Medical Center. I'm originally from India. I did my residency in Chicago at Advocate Illinois Masonic Medical Center. As far as my future in cardiology, I'm considering either electrophysiology or intervention, but I'm still figuring it out. During my free time, apart from cardiology, I love to rollerblade or ice skate, depending on the season.
Well, Mohan, that's plenty of time for you to figuring out what you want to do further. Well, you just started your fellowship, so no rush. Take all your time.
Yeah, that's fantastic. We'll have to talk about Chicago another time too. It's a great city as well, and certainly for foodies. But we are today in Omaha, and so I would love to hear more about some of your favorite things to do, favorite places to go in Omaha, and maybe somewhere we can go today to talk about this case.
Yes, definitely. How about I give you a tour of Omaha? We are standing right in front of Warren Buffett's house, and look, he is waving at us now. Going further, we are on a very beautiful bridge called Bob Cherry Pedestrian Bridge, where we can see many couples and family taking a good stroll. So after having a good leisure walk, now we are at the famous zoo called the Henry Dooley Zoo, and we are enjoying a late night show in zoo.
That's amazing. It sounds like a wonderful day in Omaha and a great opportunity to talk about a case here at the zoo, or maybe even Warren Buffett will be able to overhear us in the background. But why don't you get us started in this case?
Let's start with our case today. We have a 76-year-old female that presented to the emergency room with complaints of progressively worsening dyspnea over the last few months. She also has lower extremity edema with a new pleuritic chest pain and cough over the last 3 days. She does have history of heart failure with preserved ejection fraction, for which she was being treated with diuretics. Her other history includes hypothyroidism, for which she is on thyroid supplements, monoclonal gammopathy of undetermined significance, COPD, diabetes, and history of squamous cell carcinoma and basal cell carcinoma. On presentation, she was tachypneic, hypoxic as well, and cardiology team was consulted for possible decompensated heart failure.
What we have here is an elderly female with some exertional shortness of breath. So definitely heart failure exacerbation is one of the possibility given her lower extremity swelling. You mentioned she also had COPD, so this could definitely be a COPD exacerbation as well. And with her chronic chest pain, this can be pulmonary embolism given her cancer history, or this could be pericarditis. Some of the other differentials with her shortness of breath and swelling include kidney and liver disease. So, Mohan, do you want to tell us about the physical exam?
Yeah, Mansi, let's go over the physical exam. I think the differentials are pretty broad at this point. So let's start with the vitals. She was febrile and hemodynamically stable on presentation with a blood pressure of 113 over 76 mmHg. Her heart rate is 99 beats per minute. She is irregularly irregular. She is tachypneic with a respiratory rate of 28 and she is saturating at 93% on room air. She is morbidly obese. Her BMI is around 40. She had elevated P with a positive Kussmaul sign. Her rhythm is irregularly irregular and she had normal in S1 and S2 sounds, but I think they were of a little bit lower intensity than what I was expecting. I did not appreciate any murmurs or gallops. There was decreased breath sounds in bilateral lower lobes of the lungs. I did not hear any wheezing. Her abdomen was distended and she had 2+ pitting bilateral lower extremity edema.
Well, that was a very thorough physical exam. And after hearing that, I'm leaning more towards heart failure exacerbation, given her signs of volume overload, which you mentioned, with her elevated JVT, pitting bilateral lower extremity edema. You didn't mention any V's.
Yeah, I did not hear any wheeze.
Okay. So COPD seems to be less likely here. Well, what did you mention? You mentioned about Kussmaul sign.
Yes.
Yeah. Can you please tell us what it is and where we can see it?
Yeah, Kussmaul sign is one of the physical exam findings that we can see in a few pathologies. It's paradoxical raise in JVP during inspiration. So usually with inspiration, there is a kind of suction created in the thorax and the negative pressure brings in blood. So there is increased venous return. But when your heart is unable to accommodate that increased blood flow, it results in elevation of JVP, which is paradoxical. So it's usually seen in conditions where there is stiff myocardium, or if there is severe pulmonary hypertension, or if the pericardium is constricted, or it can also be seen in like tamponade or severe RV dysfunction.
Well, Mohan, that was a very nice explanation of Kussmaul sign. So can you please walk us through her lab so that we can narrow our differentials?
Yeah. So she is mildly hyponatremic. Her sodium is 132. Her potassium is 3.4, mildly hypokalemic, and BUN and creatinine are within normal limits. Her alkaline phosphatase is 116, serum bilirubin is 1.9, calcium is normal, her proteins and albumins are also normal. Her hemoglobin is 11.2, I'd say mildly anemic. WBC and the other components of the CBC are fine. We got high sensitivity troponins, which are normal. We got CHF peptide, which was normal, 84. We got TSH, which is mildly elevated, 6.68, and CRP, which is mildly elevated as well. So her EKG did show atrial fibrillation with rapid ventricular response, and we were able to appreciate low voltage QRS complexes there.
Yeah, that's interesting. I was expecting her CHF peptide to be elevated if I was thinking of heart failure, but I recall that you mentioned she was morbidly obese, so maybe due to her morbid obesity, it's low.
Yeah, Mansi, that's a good point. Morbid obesity can sometimes lead to low CHF peptide, but still heart failure is on my differential. But with her pleuritic chest pain and tachypnea, which is relatively new, pulmonary embolism is something that I would not want to miss in such a patient. So we went ahead, we got CT chest with a pulmonary embolism protocol. Fortunately, there was no pulmonary embolism that was seen, but she did have diffuse pericardial calcification seen on the CT.
Oh, wow. Yes, Mohan, ruling out PE is very, very important. It's interesting that we saw the pericardial calcifications. This is not something you see often. Now I'm leaning more towards constrictive pericarditis. Mohan, did she have any prior history of radiation or heart surgery which you can recall?
Well, I was looking for the causes of the pericardial calcifications there as well. So she had history of squamous cell cancer and basal cell carcinoma on the extremities, but she did not have any radiation. There were no prior cardiac surgeries or prior myocardial infarctions, no known episodes of acute pericarditis in the past. She did not have any connective tissue disease or no history of tuberculosis or any international travel for that matter.
Yes, Mohan, these are all the important points you covered in the history. But in most cases, we usually do not find a definitive cause for constrictive pericarditis.
Yeah, that's true, Mansi. Though constrictive pericarditis climbed up the differential list, with a history of heart failure with preserved ejection fraction, I'm still considering constriction versus restriction. I'm eager to take a look at her echo actually.
Yeah, and before we look at the Echo, which is obviously going to be pretty exciting, Echo is a great tool, and as an imaging fellow, something I definitely get excited about. I just wanted to congratulate you all and really point out the way that you kind of updated your differential throughout the case and how important that is and how great that is to see. I think we've all had that experience of anchoring on a diagnosis. And the way that you all have really masterfully ruled out different things while keeping things in the background, thinking, oh, heart failure is what I'm thinking of, but I want to make sure there's not a PE. Oh, there's pericardial calcifications. That's going to update my differential. You all have done a really fantastic job with that, and I'm excited to see what we have next.
Thanks, Rick. And Mohan, definitely we got her echo. It was extremely challenging to get good images on her. We tried to use enhancing agents, but given her morbid obesity, it remains difficult to get some good pictures. And on top of that, she was in atrial fibrillation, which complicated the imaging acquisition and interpretation. Overall, she had a preserved left ventricular ejection fraction of 55 to 60%, no gross wall motion abnormality, and unclear septal motion in the setting of AFib, but we didn't appreciate any pericardial effusion.
Well, that's a bummer. I was actually hoping to get some information from the echo, but in an ideal scenario, what are we looking for in the echo in such patients?
Yes, well, that's a very important question. And to answer that, let's first understand the physiology behind constriction. So normally, when we inspire, our intrathoracic pressure goes down, which is transmitted to the heart, leading to increased venous return and filling. However, in constrictive pericarditis, the heart is encased in this thick, non-confined pericardium, because of which these intrathoracic pressures, they are not able to be transmitted to the heart, but they transmit to the pulmonary veins, which are outside of the pericardium. So because of this, there's reduced gradient, or in simple terms, less driving pressure between the pulmonary veins and the left side of heart. Hence, there is reduced filling of left ventricle during inspiration. However, there is increased filling of the right ventricle, and since it's not able to expand enough within the thick pericardium, there is bowing of the septum towards the left ventricle, further compromising the left ventricular filling. So sad for the LV. So, however, during expiration, LV thinks, no, I want my position back. So he drives the septum back towards the right ventricle, and there is increased LV filling. So this competition between the right and the left ventricle is called the ventricular interdependence, which is a very key finding which we see in constrictive pericarditis.
Well, that's an interesting concept and beautifully explained, Mansi. I believe I have a better understanding now. I still find it challenging to differentiate between the constriction and the restriction physiology. How can we look at this?
Since both constriction and restriction affects the diastolic filling, and it can present with signs and symptoms of the right-sided heart failure, just like our patient. But we need to understand in constriction, we have a very stiff pericardium. Problem lies with the pericardium. Because of which the RV and the LV, they are fighting against each other, and we talked about that ventricular interdependence. However, In restriction, we have the problem with the myocardium. It's too stiff. And the RV and the LV, they are not fighting against each other. They both are bad. So there is no ventricular interdependence. So based on this, we see respirophasic variations in constriction with reduced microvent flow velocities with inspiration and reduced tricuspid velocities with expiration. Also, normally we see lateral tissue velocity is higher than the septal velocity, but in constrictive pericarditis, the lateral wall is adhered to the pericardium, so we find higher septal velocities in constriction, which is called annulus reversus. In restriction, since there is an intrinsic myocardial problem, both septal and lateral tissue velocities are low. I know it's a lot, but I hope this helps.
Definitely, Mansi. I'm actually amazed at how these fundamental concepts comes to life in echo. It's a thrilling reminder of just how beautiful the cardiology field is.
I fully agree with you, Mohan. The physiology and hemodynamics is what fascinates me as well. So coming back to our case, since we did not have good echo images, we say, did we proceed with invasive hemodynamics?
Yeah, Mansi, we got invasive hemodynamics on her. So we did simultaneous RV and LV catheterization. So her pressures are like this. She had elevated right side pressures. Her right atrial pressure is 14. Her RV and diastolic pressure is 16. Her pulmonary artery pressures are 37/16 with a mean of 25. Her wedge pressure is 16 and left ventricular and diastolic pressure is 80. So the simultaneous tracings did show that there was ventricular discordance, and I think essentially it's the same concept of interventricular dependence, which we are expecting in her. Also, there was diastolic equalization of the RV and LV. So we also saw a diastolic square root sign with early dip of the diastolic pressures followed by a plateau.
So yes, based on those invasive findings, we have basically ventricular discordance. So that formed the constrictive physiology. But also remember, we were not able to get good echo images. So we got an MRI on her and it showed diastolic septal flattening with deep inspiration. That is the D sign. Both are suggestive of constrictive physiology as well. So now that we have a definitive diagnosis of constrictive pericarditis through these multimodality diagnostics, Mohan, how did we manage the patient?
So you all have done such an amazing job with this case. I really encourage any listeners to go to the website and watch some of the accompanying show notes and the materials because there's so much to learn here. And one of the things you pointed out that is, clinically just the case all the time is that the imaging was challenging, right? This isn't a test question. You don't always get the best imaging. But even on the imaging that you were able to provide, you can see that kind of septal shudder or septal bounce, right? And abnormal septal motion is one of those things. It's almost like if you remember watching House back in the day, that's kind of an old show. People see abnormal septal motion and they immediately think, oh my gosh, it's constriction, and they run it and you realize, oh no, it wasn't constriction, it was something else. And so I thought it might be helpful to just review a few of the things that I think about when I see abnormal septal motion and some of the things that are good to rule out. You've talked at length about constriction already, and so I think we can hold off on that. But I'll say the constriction in general is a pretty rare diagnosis, right? And there are other things that we're going to see more commonly. One of the things you want to look for when you see abnormal septal motion that is right there in front of you, often even at the bottom of the echo screen, is the ECG recording. Paced rhythm or bundle branch blocks can lead to abnormal electrical activation. So you can have abnormal septal motion secondary to that. And so one thing to look at in this situation that you can get to either on the screen or at an adjoining screen or, looking up on a sheet of paper is that ECG recording. Other things to think about, and you touched on this a little bit is post-operative state. So has their pericardium been opened in the past? If they had heart surgery in the past? You might have seen on echo reports post-operative free motion of the septum in that setting. And then something else to think about is the RV function. And so we've all seen those really large right ventricles with a D-shaped septum, but sometimes it can be a little bit more subtle. And so looking at the right heart, especially in a parasternal short axis window, can be really helpful in these situations too. That said, you all have done an incredible job keeping the differential broad. You've really gone through the data in a really succinct and excellent way. And so I'd love to hear the rest of the case.
So, Rick, those were all very excellent points. And thank you for this oral discussion on the abnormal septal motion.
Yeah, I definitely learned a lot of new things.
Okay, so now that we have a definitive diagnosis of constrictive pericarditis through these multimodality diagnostics, Mohan, how did we manage the patient?
Yeah, Mansi. So her management was a little bit tough. We initially uptitrated her diuretics, but she continued to have symptoms. We eventually involved CT surgery team for possible pericardectomy. They discussed the care with the patient and spoke to her about her options. But after discussing the risks and benefits, the patient actually opted for medical management. So she was discharged with close outpatient follow up. But however, her symptoms were getting worse with weeks passing by. She did not respond even with escalating doses of diuretics, and eventually palliative team was involved and patient opted for hospice care at that point.
I think she was in a tough spot with all her comorbidities and advanced age. She was at high risk for surgical mortality, and I think we did the right thing involving the palliative team.
Yeah, I agree with you, Mansi. She's definitely in a tough spot. We often encounter such scenarios in our clinical practice, and I think shared decision making and involving palliative team can immensely benefit patient and it helps better navigate such scenarios.
Yes, I completely agree with you on that, Mohan.
Yeah, really, as you mentioned, this is tough, right? And it's part of the work that we do. It's a really important part of the work that we do. Having challenging outcomes is really hard. That said, you all clearly thought really deeply on this case and put a lot of time into the care of this patient. And that matters. And that matters. And so thank you so much. I think that, I personally learned a lot listening to this case today. I know there are things that I want to go back to. Some of the imaging for this case is really, really tremendous. And there's a lot that all of our learners can take away. I'm really grateful that I got to spend the time with you here today in Omaha and to learn about constrictive physiology.
Yeah, and I'll chime in. I definitely appreciated you going through this case and highlighting all of the key facts about constrictive pericarditis. And, when we think about this diagnosis, I think it cannot be highlighted enough. What we said, it's sometimes really challenging to make the diagnosis. You're going to often have to use multimodality imaging and physical exam, obviously. And, just thinking about the heart as a locked box, if you have some sort of shell that basically, makes the right ventricle and the left ventricle fight each other. It's kind of like they share space. They're in this apartment. Each one has a room, but they can't really expand outwards and they share that middle wall. Constrictive pericarditis puts the right ventricle against the left ventricle so that when one wins, the other one loses. And that's never a good thing. And making the diagnosis can be really challenging. And also it's really important to make the diagnosis because it has so much ramifications. What I find challenging about making the diagnosis is that the ramifications are so profound. I mean, in your case, your patient had an understanding of where they wanted to go in terms of goals of care, and that was extremely helpful navigating the plan. But for other patients, it's challenging. And the surgery that is required here is no benign surgery. I remember once when we were in fellowship, there was a question of whether or not somebody should do pericardial stripping. And there was a surgeon in the room, and one of the cardiologists mentioned, hey, why don't you just get in there and just remove the pericardium? No big deal. And the surgeon explained that no, it's actually a pretty morbid surgery. Often they have to peel off the pericardium piece by piece. It can be quite complex. And also they have to expose so much of the heart to get to it. So when you build a case for constrictive pericarditis, sometimes it really requires a lot of evidence to support that diagnosis because obviously you want to get it right because you really want to help the patient, especially if they're going to be undergoing such a intense surgery. So it's always really important to review these concepts and go over them. And you guys did such a great job. This truly was a masterclass whirlwind tour throughout that. So I really appreciate that. And of course, Rick's comments about the septal wall motion abnormalities that all the time we see in the reports and we want to know more about and understand what's going on. So thank you guys. This was just such a great, great conversation.
Thank you so much, Rick and Dan. You highlighted all the important points, specifically about pericardiectomy. just I want to add a small note, like this should be done at the specialized centers because sometimes even if they miss some piece of pericardium, the patients can develop like recurrent pericarditis. Let's just summarize the key learning points first. If the patient is presenting with the right-sided heart failure and is not responding to escalating doses of diuretics, it should always raise a concern for constrictive pericarditis. And sometimes we need to make further investigations with different imaging modalities to establish a diagnosis like we did in our case. And it's important to distinguish between constriction, restriction, and overall picture for the patient. What's their goals of care? What are their comorbidities? So these are some points which this case taught us.
Thank you all so much. What an incredible case.
So we have our expert here, Dr. Adam Burdorf. He is our program director and he is simply amazing. He is personally my mentor. I have done 1 year of clinics with him, and let me tell you, I have enjoyed the most during my fellowship. He has such a good sense of humor. He makes me smile. He makes all the patients smile. So now we will hear from Dr. Adam Burdorf.
Hello, and thank you for having me. My name is Adam Burdorf, and I am the program director for cardiovascular medicine at the University of Nebraska in the heart of Omaha. In my spare time, I also practice as an advanced heart failure and transplant cardiologist, and I am the current medical director of mechanical circulatory support. In regards to our fellowship, every year we have the opportunity to welcome 7 new fellows along with advanced fellows in heart failure and transplant, interventional cardiology, electrophysiology, and now adult congenital cardiology. And our partnership with Nebraska Medicine allows us to be part of a campus that is always growing, allowing us to meet the demands of our entire region. We're proud to be home to the Davis Global Center, which is a state-of-the-art simulation center housing simulated operating rooms, endoscopy and echocardiographic suites, as well as a holographic theater and augmented reality learning modules. And I encourage you all to check it out on our website if you have the time. Although our fellows will likely say that I am the best part of the program and I'm what makes it incredible, at least that's what I pay them to say. I think what really makes our fellowship special is the size of our program and the people we work with. We're a large enough program where you will see a myriad of cardiovascular pathologies and disease processes, but not so big that you're getting lost amongst other trainees and staff. Our fellows really know everyone in our division, and this allows for collaboration across subspecialties and a relaxed but engaging work environment. I think our graduates would agree that when they leave our program, they're very well trained and ready for independent practice when they're done here in Omaha. Our community as a whole is a moderate-sized Midwestern community with lots of great restaurants, live music, parks, and other recreational areas, which make your time outside of the fellowship more enjoyable as well. I can speak for myself and my family that when we came to Omaha, when I began training, the plan was certainly not to stay, but we ended up really falling in love with the med center and the community as a whole, which made our decision to settle down here quite easy. A bit about our case. Constrictive pericarditis, while not as common as other cardiovascular disease processes, is certainly out there. And it will see you, so you certainly have to be able to see it. What I mean by that is that when someone presents with signs and symptoms of heart failure, if you don't at least have some moderate level of suspicion and you don't ask the right questions, you're likely to miss this sometimes elusive diagnosis. Anecdotally, I feel like when I have patients that have symptoms that seem like traditional right heart failure symptoms, so ascites, lower extremity edema, maybe a pleural effusion, I think of 2 disease processes. I think of restrictive cardiomyopathy, and I think of pericardial constriction. And this is really where your history and physical do you a real service. And you have to ask appropriate questions to tease out the patient that may have a diagnosis of constrictive pericarditis. More specifically, if you look at the etiology of constrictive pericarditis, things like chest radiation or previous malignancy, rheumatologic conditions, and to some extent, even in developed countries, infectious etiologies, if you can tease out those parts of the medical history from your history, it makes the diagnosis much easier. So When you have an individual that has heart failure symptoms predominantly, who maybe has a normal ejection fraction on echocardiogram, your suspicion for these other disease processes should be raised. Then your next task is to support your differential with testing, serologic studies, etc. For me, the echo is not necessarily always specific for constriction. It may give you some hint as to constriction, but really the cardiac MRI is maybe our imaging modality that gives us the most bang for our buck. This sometimes too is a time when you can look through previous imaging studies. Let's say, for example, the patient had previous CT scan of the chest. You may be able to see pericardial thickening, which would suggest the possibility of constrictive pericarditis as well. So we can kind of look through the medical history and the rest of the electronic medical record to try to find things that support our diagnosis. When I think I have a patient that may have constrictive pericarditis, they have the appropriate history, physical exam findings. As aforementioned, I always order a cardiac MRI, and I typically will do a right heart catheterization with concomitant LV pressure tracing. Things to look for on your invasive hemodynamic studies may include the dip and plateau sign of your RV pressure tracing. Again, this is not necessarily specific to constrictive pericarditis, as any condition that causes stiffening of the pericardium or the myocardium will cause early, rapid, unimpeded filling with subsequent abrupt cessation of said filling and the plateau due to the non-compliant myocardium or non-compliant pericardium. However, the real telltale sign of constrictive pericarditis in regards to invasive hemodynamics comes down to simultaneous RV and LV pressure tracing. Typically, upon inspiration, we have increased preload to a very compliant myocardium and pericardium. And so changes in cardiac output are insignificant as a result. However, in the case of constrictive pericarditis, as a result of increased preload to a confined intracardiac space, the increased volume to the right ventricle results in bowing of the septum and decreased filling of the left ventricle. This can also be seen on cardiac MRI during different phases of respiration in regards to the septal position. What is often overlooked is the relationship between the great vessels of the heart and the intrapericardial component of the heart itself. What we see is intrathoracic and intracardiac dissociation. In other words, due to the fact the great vessels are not located within the pericardium, they are not subject to the constriction of the pericardium that occurs in constrictive pericarditis. So as you can imagine, with inspiration and a fall in intrathoracic pressure, the pressure exerted on the great vessels falls, whereas the pressure exerted by the left atrium does not. Therefore, we have no gradient to flow between the pulmonary veins and the left atrium, further decreasing the filling of our left side of our heart. These two findings combined will result in discordance upon simultaneous RV and LV pressure tracings. So as I have my Swan-Ganz catheter parked in my right ventricle and my pigtail catheter parked in the left ventricle, I have the patient take deep inspiration and deep expiration while decreasing the sweep speed of my hemodynamic monitor. This will allow me to see if the RV pressure and LV pressure are dissociated. In other words, when RV pressure increases with inspiration, does LV pressure fall at the same time as a result of the bowing of my septum towards the LV to accommodate the increased preload, as well as a decrease in the gradient from my pulmonary veins to the left atrium as a result of the fall in the intrathoracic pressure, which results in a fall in the pressure within the pulmonary veins, yet stable or increased intracardiac pressures as a result of the fact that the constricted pericardium insulates, so to speak, the intracardiac structures from these changes in pressure within the thoracic cavity. Again, this is intrathoracic and intracardiac dissociation. To summarize, in a patient where you have the appropriate clinical suspicion, i.e., the patient has a history that supports the potential diagnosis of constrictive pericarditis, as well as appropriate imaging, whether it be echocardiogram, cardiac MRI, or even CT scan, and the findings of RV and LV discordance, the likelihood your patient has constrictive pericarditis is fairly high. No one test is perfect, and therefore I feel that the multimodality imaging as well as the appropriate hemodynamics are imperative in order to make this diagnosis. Why is it important? Well, the only true treatment for constrictive pericarditis is pericardiectomy, which is a very difficult surgery, and therefore it's recommended that patients should be seen by a very skilled surgeon at a high volume center if possible. It may be reasonable at times to attempt to appropriately diurese these patients if they are only mildly symptomatic. However, most of the time patients are coming to providers as a result of profound symptoms and will need surgical consideration to alleviate their symptoms. Thank you all very much for your time, and I hope you learned something today, and I hope sometime we get to welcome you to the University of Nebraska Cardiovascular Medicine Disease Program.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.